All right, we're good now. So great to be able here today and start this off, and so thankful to John Mark for putting all this together. I've got a PowerPoint to share, so I'm going to pull that up for you. Should be right there. All right, awesome. So today we're going to talk a little bit about osteogenic loading, what that is, and then talk about vitamin D3 and vitamin K2 and how they affect bone health. And I'm Dee Matchett. If you don't know me, I have a facility called OsteoStrong where we implement osteogenic loading in order to increase bone density. I'm trying to find my little, here we go. So this is from the National Osteoporosis Foundation. Some of the things they recommend for building bone, recommendation is for high impact and weight bearing exercise. So the examples of high impact exercise would be dancing, high impact aerobics, hiking, jogging, running, jumping rope, stair climbing, tennis. These are pretty intense activities. Examples of weight bearing would be lifting weights, using elastic exercise bands, using weight machines. The reason they recommend this is because to build bone, you have to load the bone. And we have research that shows, you can see I've got my references on here. When this is shared, you can always look up these references. So it takes 4.2 times your body weight. You have to have that much impact on the bone to increase density in the hip. It's actually different for different parts of the body, but this is the common one that everybody quotes. But like for ribs are smaller bones, so it only takes 1.5 times your body weight. So it does vary depending on what part of the body we're trying to increase bone in. But I just wanted you to look at other activities and what they do. So when we do this loading of the bone, that's called osteogenic loading. Osteogenesis meaning new bone. So if you're swimming or bicycling, those are great exercises, but you get 0 times your body weight, so they don't do anything to actually build bone. Walking is a low load. You get 1 times your body weight. Moderate would be running. That's like 2 to 3 times your body weight. You get that kind of impact when you're running. So if you're high would be like jumping, like playing basketball, those kinds of things where you're really, really jumping up and down. You can get around 3 times your body weight. So notice none of those are the 4.2 required for hip. And when you're doing these activities, you're primarily getting impact through your heel. So we're looking at hip, okay? So by the way, you need to have a DEXA scan done before you do all this running and jumping because you could cause fracture if you know you have bone loss. This is those things you need to talk to your physician about before engaging in those kind of high impact activities. So this is a quote from the study over here that was done in 2012. Habitual levels of high, but not moderate or low impact activities are positively related to hip bone mass density. That's what the BMD stands for. Impacts below this threshold may have little benefit, relatively little effect on bone mass density. So at OsteoStrong, we're doing osteogenic loading. We're emulating the effect of high impact and weight-bearing exercise on the musculoskeletal system without the risks that are involved in those high impact activities. So it depends on positioning. Someone is always there to make sure you're positioned properly. We're isolating an optimal range of motion that has been observed to increase bone density for various parts of the body. We have stations for upper body, low body, core, which is the rib cage, and spine. So also there's this loading that's involved. So we're emulating impact in multiple directions beyond what regular exercise achieves because we're not isolating a motor unit group like you would like if you're doing bicep curls. We're actually able to recruit more muscle for that activity, so it emulates high impact. And then triggering, we put an individual's weight into our system, into the computer, and we do ongoing data collection with that. And so we find the target that individual needs in their body to create osteogenesis. with this self-limiting exertion that we're doing, and you have to hold that position for 5 seconds in order to trigger this osteogenic response. So I know that's a lot of information. I would go into a whole lot more detail if you actually came to my facility. But what we're doing with osteogenic loading is actually based on Wolff's law. And Wolff's law has been around since 1892. Dr. Julius Wolff discovered that if you got enough an impact on the bone got stronger. Since that time, there have been over 25,000 studies demonstrating Wolff's law. So we know when you compress and release the bone, it creates what we call fluid shear stress. And I'm going to explain what happens when we do that. So fluid shear stress then moves the interstitial fluid, and there are little osteocytes in there. When we put pressure on and move that fluid, it starts a signaling pathway telling the bones telling it to increase osteoblast production. So those little osteocytes are very sensitive to fluid motion, but it does take a lot of pressure to get them to move. But when we do, they're very, very responsive, and they increase osteoblast production. So there's your reference for that. But we know that it takes 5 seconds of that pressure to make that result happen. So this is called single short shear stress. And that differentiation, once it starts that signaling pathway telling more osteoblasts to be created, that lasts about a week. And so then you have to come back and weekly re-trigger that response in your body. So the method is really effective because it addresses both sarcopenia and osteopenia. Sarcopenia is a loss of muscle. You can see this poor little guy doesn't have anything, and here he is all pumped up. I won't promise those kind of results, but it's a cute picture. Anyway, so we're working with both. You're increasing muscle strength and skeletal strength. And so both of those affect bone density and muscle density. So you can see these little myofibrils inside this motor unit of muscle, and the signaling pathway also triggers myofibril growth. So you get a denser muscle. Works in a different way than lifting weights does. I can go into that more detail later. I don't want to spend a lot of time here because I want to get to our subject. So when we create this little response with osteogenesis and that signaling pathway starts, it is still going, oh, where are all the nutrients that I need to build bone? So we can trigger that pathway, but the body's still going, I need calcium, I need magnesium, I need vitamin D, I need K2. It's still looking for all of those things. And today we're going to talk about 2 of those that it's looking for. It's looking for vitamin D and K2. So these are things your body really, really needs for building bone. Vitamin D is a fat soluble or oil soluble vitamin. So it's going to primarily be found in fatty foods. You'll find it in egg yolks, in salmon, tuna, cod, those things that have a lot of those fatty kind of oils. Mushrooms absorb it from the sunlight, but I've looked that up. You'd have to eat so many mushrooms, it's ridiculous to get enough vitamin D. But so you want to look for foods that are rich in vitamin D. In the United States, this was a survey done in 2011, there are overall 42% of people are deficient in vitamin D. 74% of the elderly are deficient in vitamin D, and 82% of people with dark skin are deficient in vitamin D. So we find this is a pretty common deficiency for people to have. I want to talk a little bit about how your body synthesizes vitamin D. We can get it from the sun or from those foods that you're eating. When it's coming in from the sun, it comes in as a provitamin, and then it's transferred, synthesized in the skin in response to the sun, and then it's called cholecalciferol. Goes to the liver where it becomes 25-hydroxy-D or calcidiol, and then it goes to the kidneys. You can also, the way plants do this from the sun is that it enters as a provitamin called ergocalciferol, goes through a synthesis process and becomes that ergo calciferol, and then it goes right to the liver, becomes the same thing, 25-hydroxy D, and then to the liver also. So they follow the same pathway once they get to the liver. So either source through our skin, or you could eat these plants that have already, created the vitamin D. So what do we know about supplementation? Sorry about that. Some of this has gotten a little off when we transferred. So we're going to talk about supplementing, because unless you get a lot of sun or eating a lot of these fatty foods, you're probably not going to get enough vitamin D. That's why we have so many people that are deficient. So here's what we know, and it makes sense. Vitamin D2 is less potent than D3. It has a shorter duration of action. So when you take vitamin D2, it doesn't last for as long in the body. Sorry about that. So if you're taking vitamin D3, it has a higher circulating level. So if you take it, you don't have to take as much of it because it stays in circulation longer, and those levels are sustained for longer. So there's really no debate about this. Most physicians will say it's best to take vitamin D3. This is pretty common knowledge. So I have people ask me all the time, well, how much vitamin D should I take? And there really is a better question than that. The better question is, what serum level of vitamin D is needed to build bone? So we're measuring in the body, in the blood. You can do blood work for this and run lab to test for that 25-hydroxyvitamin D, the calcidiol. So the body converts vitamin D into that. We already talked about that process. And then we can run this 25-hydroxyvitamin D test to monitor those vitamin D levels. And if you haven't had that done, it's just so simple to do, and it can be run with your regular blood work, not difficult. There has not been a optimal concentration in the blood determined, because they think this probably varies quite a bit by your stage of life, by race and ethnicity. There's lots of things that affect it. So in other words, your serum level might need to be different at age 25 than it would be at age 65. So these are things you're going to have to let your physician help monitor. But I want to talk a little bit about the test itself and the ranges on the test. So this is according to the Office of Dietary Supplements. Levels of vitamin D are measured by the hydroxy level in nanomoles per liter or nanograms per liter. Mostly you'll see it as nanomoles per liter. So that's what we're going to talk about today. So the results can indicate the following. Deficiency is less than 30 nanomoles. Potential deficiency between 30 and 50. So at deficiency level, if you're less than this, you're going to have symptoms of deficiency, okay? But you could have them between 30 and 50. Everybody's kind of different. Normal levels then are between 50 and 125, and high level would be more than 125. You can become toxic taking too much vitamin D, which is a good reason to have blood work done for this. I see anything from 125 to 150 listed as toxic. So you don't want to get up in this range. You want to stay down in here between 50 and 125. So this is from the National Institute of Health fact sheets. You can go to the website and see this information. And this is a quote from the Endocrine Society's Clinical Practice Guide. The Endocrine Society stated that for clinical practice, a serum 25 concentration of more than 75 moles is necessary to maximize the effect of vitamin D on calcium, bone, and muscle metabolism. In other words, in order to affect bone, we're going to need more than 75 moles of this vitamin D. So I can't tell you how much to take to get there. You're going to have to look at blood work to determine how much you're going to have to take. It may take a little experimentation. So just kind of confirming that, this is from a Well-Woman clinic run by Dr. Shiak, who's an OBGYN. You can go and see this information on her site. She's saying that at her clinic, she's finding a deficiency at less than 50. Remember, the other one was 30 to 50. So this is inadequate for bone health. 50 to 70, probably adequate for maintenance. Okay, that's what they're discovering there. And for a therapeutic level, if you have osteoporosis, between 70 and 100, and she's calling anything over 100 an excess. So she's trying to keep it in this range. My own nurse practitioner is wanting me to stay within like 80 to 100. That's her range she's looking at. So it kind of depends, but this is pretty much a norm here that they're, for bone anyways, you're looking at this kind of range. The endocrine society said 75 or more, above that. So anyhow, you can kind of see what kind of range you need to stay in. The range varies with tests on the lab, but the common one is 300 to 100 moles. If you are 30, that's not going to flag. Okay, so your doctor is not going to give him a red flag saying, oh, you know, you're deficient if you're at 30. I'm just telling you, you need to look and see that that's not sufficient for building bone. So we do an intake at our place to just ask people what their vitamin D level is. And if they don't know, we're trying to encourage them to go and find out from their physician so they can get optimal results with osteogenic loading. 50% of women undergoing treatment for osteoporosis have inadequate levels of vitamin D. So this is a concern. Caution, supplementation can change vitamin levels very quickly. So you want your healthcare provider monitoring your levels to determine how much vitamin D your body requires to maintain desired levels. So I know that's not an easy answer to how much vitamin D should I take, but it really is the best way to find out. And you're going to have your physician work with you to monitor that. So we're doing good on time. I hope so, because we're going to talk about vitamin K. And we're actually specifically talking about K2, and its active form is MK7 in the body. You'll find it in fermented foods that have not been pasteurized. So sauerkraut at the grocery store won't do it, but if you make it yourself, it might. Just it takes certain types of fermentation that have not been altered. So certain cheeses, we'll talk about that. And then this is natto, which is a fermented soy. So let's talk about how vitamin K acts on the bone. So whatever your source is for K2, whether it's food or a vitamins type supplement, it's going to convert into MK7 and go through this carboxylation process. And then you can see where calcium from the bloodstream connects to it. And it's like the carrier that carries calcium into the bone. So you can take all the calcium you want, but if you don't have enough K2 to carry that into the bone, it doesn't adhere and create new bone for you. So you can see how important the K2 is in this process. So I'll talk a little bit about K. There are actually two types of K, K1 and K2. K1 is phylloquinone, and let's see if we can pull that down. K2 is menaquinone. And there's actually groups within that. So we look at K2 as MK and a number. And we're going to talk about MK4 and MK7 today. MK1's function is blood clotting. So K2's function is calcium direction. It directs calcium into bones or out of soft tissue, preventing calcification. So if you have calcifications, it may be that you have a K2 deficiency, so that it's not removing calcium out of soft tissue. In our diet, 90% of the K we eat is K1. So that's just our modern Western diet. We have primarily K1 in our diet. Your body does convert some K1 into K2, but we are not real efficient at that. K2 sources, there are not very many in our Western diet, but we're going to talk about those. So K1 sources are green leafy vegetables, and usually it's in your multivitamin. K2 sources would be unpasteurized fermented foods. You'll get MK4 in Gouda and Brie, and your body's going to transform that into MK7. Natto, which is that fermented soy, and Adam is a cheese. These are actually, the bacteria has already converted it into MK7. You can get it in grass-fed meat and grass-fed dairy. So these are just things that we don't generally have in our diet, but you might want to look towards adding them. And it's not usually in your multivitamin. The RDI for K1 is 120 micrograms for men and 90 micrograms for women. That was based on coagulation tests. For K2, it has not yet been determined. Toxicity is rare for both because it's probably not going to eat, tons of green vegetables enough to get toxic, or these other foods enough to get toxic either. Primary action for K1 is that it travels to the liver and forms clotting proteins. K2 travels to the bone and forms osteocalcin proteins that adhere then to the bone. So you can get interference taking K1 supplements with any kind of anticoagulant you're on. There is question about K2, and you might want to look at this study right here. He's saying he was able to give K2 to elderly patients with osteoporosis and not have any hemostatic activation, but this would be best to consult with your physician on before you take a vitamin K2. So comes in supplement form. Most people are having to go to the supplement form of K2 because we're just not getting sufficient in our diets. MK4 is a synthetic. It is poorly absorbed and has a shorter half-life. So you're having to take it multiple times during the day to keep sufficient in the bloodstream. And so it requires a higher dosage and more frequent dosage. MK4 is the preferred supplement form. You can get it naturally from the natto and they create a supplement from that. Or you can get the synthetic. MK7 has a longer half-life, requires a lower dosage, and you only have to take it once a day. So if you're doing MK4, the recommendation is 15 to 45 milligrams 3 times a day. MK7, you're taking it in micrograms, which is a much smaller dosage, once per day. Most of the research, early research at least, is done with MK4 because that was what was available at the time. So this is from a study done in 2000 where MK4 successfully inhibited the occurrence of new bone fractures and maintained, this is lumbar bone mass density. This is the first report showing the effects of vitamin K2 on trabecular bone and on bone fracture prevention. So trabecular bone is the porous bone inside. Generally, we measure cortical bone, which is the bone on the outside of the bone, but this was measuring trabecular on the inside, which is really a nice result there. So this is another study done in 2000 using MK4. And this is, they divided into 4 groups of participants. One was a group that just took calcium. They actually had a 79.79% reduction in bone mass density. This was a group that took only vitamin D3. They had a 0.38 increase in bone mass density. This third group was taking the vitamin K2 only. They had a 0.9% increase. So notice you got more increase with K2 than you did with calcium. Well, calcium alone just actually was a reduction. But look at the group with K2 and D3 together. They had a 1.35% increase in bone mass. So joined together, K2 and vitamin D get better results than any of these other things. And then they also found in this study done in 2001, and this was also done with MK4, that biphosphonate treatment, which is like your Fosamax and other bisphosphonates that are usually prescribed for osteoporosis, that they were more effective when they were combined with the K2. So more recent research that we see results from MK7. So this was a study done in Norway in 2019, not that long ago, and they concluded vitamin K in the form of MK7 supplementation in postmenopausal patients appeared beneficial in combination with calcium and vitamin D3 for bone health and vasculature. Clinical studies demonstrate that increased intake of vitamin K could be a promising complementary nutrient in supporting both bone health and promoting protecting you from vascular calcifications. So therefore, it can increase safety of current treatment of osteoporosis. And this is another study just done, it was just released last year in March of 2020. This one was in Japan. It has also been shown that MK7 stimulates osteoblastogenesis and suppresses osteoclastogenesis, which is the osteoclast tear old bone away, by inhibiting the activation of NF-KB. I don't have any idea how that all, what the long term is, but I know what it does. It's a signaling that mediates rank ligand-induced osteoclastogenesis. So rank ligand promotes the maturation of osteoclasts, and so then by inhibiting that signaling, they're slowing that down. So you wouldn't have as many osteoclasts, and it's stimulating the osteoblasts. So MK7 has been shown to have the highest bioavailability and the most significant effect on osteocalcin carboxylation in humans. Vitamin K1 and MK4 at their current RDIs are not sufficient for the activation of osteocalcin. On the other hand, it's expected that MK7 may promote bone health. So that's the latest and greatest. So let's look at how we can best utilize that. Vitamin D3 versus vitamin K2, you will find they are always in this struggle because they are both fat-soluble vitamins, so they're going to compete for one another for absorption.
Hey, Dee,
so,
just letting you know, you got about 2 minutes.
Yep, got it.
Okay.
So the solution then is to take them separately so that they're not conflicting with one another. And if you take a sublingual, you're avoiding the whole fat digestive issue. So I actually did this with my nurse practitioner. She helped me increase my vitamin D from 39.4, and we played around with what method, what supplement and how much to take till we got it up into the 90s. I was really happy with that. And then I actually read this book called Rebuild Your Bones with Jason Carlton, and I began to separate and take my vitamin D separately from my K2, and I went up to 123 in about a month's time. I thought, wow, and I was actually able to cut back on how much I was taking. It worked so well. So why is this a concern for us? Because at OsteoStrong, we're averaging 7.7% increase in bone mass density in 12 months' time. So this little 1.35% doesn't sound like a whole lot. However, this is really an average, okay? And they weren't separating their K2 from their D3 when their supplementation, and they weren't optimizing those 25-hydroxy-D levels. So there, in other words, there's a possibility you could get even better than this. We're getting 7.7, but not everybody gets that. That's an average. I see people that get more than that. I see people that do not have an increase. So when that happens, we are looking for the missing factor, which is often the vitamin D. And so we are looking to get optimal results for you. And that's why this is a concern, and want to get that information out there so we can get the best results possible for building bone. So we're OsteoStrong Farragut. You can find us in Aspen Square. We'll do 2 complimentary sessions for you. Just call this number, or you can go to this website, osteostrong.me, and there is a, you can do a sign up there. Just look for my location. There's a location button, and just put in your zip code or Farragut and it will come up, or even under Knoxville, it will come up. And then if you tell us that, call or do this and tell us that you found out about it here at this expo, I'll give you a $25 coupon to use at OsteoStrong. So is that our time? We got it perfect, I hope.
You're good, Dee. Hey, Dee, if you wanted to leave any of those links in the chat bar, and for all the attendees,
Sure.
got a great, all the guests here that have viewed Dee's presentation. If you guys have any questions for Dee here over the next 5 minutes, probably what would be best is you can just type that in the chat bar and